Hello class. Today I'll be talking about blood disorders. What is their significance in dentistry? You may observe as a clinician oral soft tissue changes with evidence of petechiae, purpura, ecchymosis. You may also see lower resistance to infection. The person may bleed significantly more than usual. It may be difficult to get them to stop bleeding. You may also see exaggerated responses to local factors. You may see only a small amount of plaque or biofilm present, and yet the tissue is bright red and bleeding a lot. You may also detect an unknown condition. Someone's gingiva is bleeding spontaneously, meaning you're not touching it, you're not scaling it. They're just telling you their tissue intraorally is oozing blood, and that may be a sign of leukemia. So what are some possible indicators of a blood disorder? Things like gingival bleeding, they won't stop bleeding post-op, the bruising that I talked about. Occasionally the pallor of their gingiva is very pale. That exaggerated gingival response, bright red, bleeding, puffy, and there's almost no local factors present. The tongue papilla may atrophy, and that's something called denuded, D-E-N-U-D-E, denude. And it looks very, very smooth. Sometimes we call that a bald tongue. The person may say they have glossodynia. That is tongue pain. They may have infections that are not responding to treatment, or also severe oral ulcerations. So the first thing we'll take a look at in depth is anemia. Anemia is a reduction in red blood cells or in hemoglobin. And red blood cells carry our hemoglobin, and that actually, hemoglobin itself carries the oxygen to our cells. It's very needed. So anemia itself is not a disease, but it does indicate there's an underlying problem or condition, such as internal bleeding or a vitamin deficiency. So let's look at the different types of anemia. So what causes anemia? It could be blood loss, which could be acute or chronic. They could have an internal GI bleed. They could have heavy menstruation, pregnancy, or a hemorrhage from trauma. They could have increased hemolysis, which is destruction of the hemoglobin or red blood cells. And that could be a hereditary condition or an acquired condition, a disease process. Or they have a diminished production of red blood cells. Their body is just not making enough red blood cells, and that can be from a nutritional deficiency or a bone marrow failure due to certain types of cancers. So some clinical characteristics of anemia. So lowering that red blood cell, that redness, that richness, you can end up with tissue that looks very pale. The person may feel very weak. They're not being supplied with the necessary oxygen to their cells. Poor wound healing. That denuded tongue. Here is the atrophy of the tongue papilla. You can see how smooth it is. They may also experience disordered breathing, or they're out of breath with even the slightest amount of exertion. And then their nail beds, the nail beds themselves being at the extremities, not getting that rich oxygen from the hemoglobin and the red blood cells. Our nails can become sort of flat and brittle with pale nail beds. So iron deficiency anemia, the red blood cells themselves are very small and they lack iron. So you could be low in iron due to a malnutrition or malabsorption, meaning you're not absorbing it as well, chronic blood loss, chronic inflammation. The treatment for that is iron supplements. Iron supplements taste terrible. And the other thing that they do is they can stain the teeth. So someone that is taking oral supplements of iron may have stained teeth from that. We also have, so that's small red blood cells, and then we also have large red blood cells, and that's megaloblastic anemia. They're large, but they don't work very well. So that's not very good, right? So they're nice and big, but they're not working. And so there are two forms of megaloblastic anemia. There's pernicious anemia. We talked about that in autoimmune disorders in our other lecture. And then folate deficient anemia. Folate or folic acid is B12. It's another supplement that they're low in. So pernicious anemia is autoimmune. The autoantibodies attack the parietal cells of the stomach, which secrete something called intrinsic factor. And we actually need intrinsic factor to absorb B12. And then folate deficiency anemia, that's usually dietary, and it's especially dangerous. Oh, I see a typo. Wait a minute. Pregnancy, right? So you're always told to take folic acid supplements. Folic acid is in so many things that we eat now to prevent spina bifida. When the fetus is developing, it needs folate. If the person is low in folic acid, the fetus may develop spina bifida, where occasionally it's hidden, that spina bifida occulta. Sometimes it's exuding outside of the body in that meningeocele, and sometimes the spinal column itself, this cord, is actually coming out in that sac we see on the back of the baby when it's born, and those children will suffer from paralysis. Another thing to be aware of is alcohol interferes with the absorption of folic acid as well. Another type of anemia is sickle cell anemia, and this is hereditary. And the red blood cells become rigid and they're shaped like a sickle, kind of like our sickle instrument in clinic, like a hook. And because they're rigid, like these round red blood cells here are almost like, they're kind of like, if you've ever been like on a water slide on one of those tubes, and the thing that you sit on kind of can squeeze through the tube that you're sent through on the water slide, our red blood cells are kind of like those tubes that you sit in, that they're spongy and can kind of push through the blood vessels because they're flexible. These rigid red blood cells, the sickle cells, are very hard, and they end up getting caught in blocking blood flow. And if, excuse me, and because they block blood flow, they can cause a lot of pain if they cut off the blood flow to certain tissues or tissue death. And it can also lead to infection and organ damage because the blood flow to these cells has been cut off because the sickle cells kind of get caught up in their smaller capillaries. So how is sickle cell passed from parent to child? So you can either have sickle cell trait or you can have sickle cell anemia. So if you are diagnosed with sickle cell trait, you usually have no symptoms. You've inherited only one copy of the sickle cell gene, meaning only one of your parents has the gene. And so you'll have no symptoms, but you may pass that gene to your children. And if you happen to have a child with someone else that has sickle cell trait or that one copy, your child may have sickle cell anemia. both parents have the gene or one parent has the anemia. So that is how someone, their parents might be well, but each one of them has the trait, and their child can then have sickle cell anemia, or one parent has sickle cell anemia, the other parent is well or has the trait, and then their child has sickle cell anemia. So some dental therapy considerations for someone with sickle cell anemia. We want to have shorter appointments, avoiding complicated procedures, excellent oral hygiene education. You need to treat infections aggressively, consulting with physician, also using local anesthetic without vasoconstrictor. You don't want to make vessels constrict and make them smaller when the sickle cells already have a hard time passing through. You start making vessels smaller and blood flow gets cut off to certain things, like let's say the pulp of a tooth. The person can develop an abscess in that tooth without any decay in the tooth, trauma in the tooth. It could be just caused from the blood flow to the pulp getting cut off, leading to an irreversible pulpitis because the tooth itself is not being nourished with the blood flow and the oxygen that it needs. So it's really important that they're treated very carefully, preventing any kind of infection from developing. So no vasoconstrictors for these patients because they're at high risk of developing pulpitis and other conditions because of the lack of blood flow to cells and tissues. So hemolytic, lytic meaning death, hemo meaning blood. So the red blood cells are dying or destroyed. Hemolytic anemia is a disorder in which red blood cells are destroyed faster than they can be made. And that destruction is called hemolysis. So some of the causes, it can be acquired or it can be inherited. So you may have a mismatch of blood transfusion. So they're always very careful to make sure that you're given blood that matches, or the neutral blood type O negative is the universal donor. So I am O negative, I can give blood to anyone and they will not have a rejection of that blood. However, if you gave me A type blood, my blood would respond because that A type blood carries the A antigen. My body would consider that an antigen and would start to attack it. Also, chronic alcoholism, toxins, drugs, immune disorders, genetic disorders. So there are a lot of different disorders and disease processes which may lead to hemolytic anemia. The other hemolytic disease is erythroblastosis fetalis, and that's the hemolytic disease of the newborn. So what that is when the mother and then the fetus have incompatible blood types. So your blood type is determined by each parent. And even though it can be due to the blood type ABO blood grouping, it usually has more to do with the Rh factor. So I am O negative, my son is O positive. So there was a maternal fetal incompatibility. And so because every person, I'm going to go back a little bit. So every person is born with a blood type, O, A, B, AB, and then additionally something called a rhesus factor, named after the rhesus monkey, positive or negative. So when you're Rh negative and the other parent is Rh positive, some actual life-threatening complications can arise if the fetus inherits the positive Rh factor, like my son did. And this is called Rh incompatibility or Rh disease. And even though it sounds very serious, it's a simple treatment, which is simple and low risk. So you are delivered it's called a RhoGAM injection. So when the pregnant person and the fetus's blood systems are separate, usually, but there are times when the blood from the fetus can enter the mother's bloodstream. And if the pregnant person is Rh negative, their immune system responds to those Rh positive fetal cells as an attack and responds by making antibodies to destroy them. And this response is called Rh sensitization. Usually nothing happens because it takes a long time to build up the antibodies. The first child born usually is not affected by this erythroblastosis fetalis. However, the antibodies are made and they're waiting. And then if you are expected a second child, again, with a different Rh factor, positive, these antibodies are there, they're ready to attack. And that is when the second child could get this disease, erythroblastosis fetalis. And so they check to make sure. So when my child was born, I had something called a RhoGAM injection. And the RhoGAM actually stops my blood from making the antibodies that kill the Rh positive blood cell. So the drug itself, RhoGAM, is derived from donated human plasma, which is a blood product. And it has a very small amount of the Rh positive protein that stops your body from making the permanent antibodies. So like my body would get tricked into thinking that I had made the antibodies when I actually didn't. So that's a lot of talk about hemolytic anemia. So it gets tricky. There are very easy treatments for it if it does happen. And we will move on now since I've spent about 10 minutes talking about that. Okay. Polycythemia. Poly, I know, means many, right? Or several. So that's an increase in the number and concentration of red blood cells. So polycythemia vera, meaning primary or first, it is a type of blood cancer. It's when your bone marrow is making too many red blood cells. And when you have too many red blood cells, so we're thinking about like that red blood cell delivering the oxygen, passing through our systemic circulation into our vessels. But if there's too many, your blood actually kind of thickens, which could lead to blood clots. It can cause very serious problems. The other thing that happens is you become like more than red. You get like purple or plum color. So you may see in the mucosa sort of a very purplish color intraorally. There's another type of polycythemia, which is called secondary. And that usually is in response to chronic hypoxemia. So if you have lower levels of oxygen in your blood due to things like COPD or smoking, or another one is sleep apnea, then your body's like, oh, we're not getting oxygenated enough. I have to create more red blood cells, obviously. It's kind of fooled into thinking we don't have enough red blood cells because of the low oxygen getting to our cells. So it starts making more to get more oxygen to the cells. All right, so that's red blood cells. We're going to cover one more at the end, but that's red blood cells, white blood cells. I'll talk about that at the end. So now we're going to talk about our white blood cells. Leuko meaning white, cytes meaning cells. So these are just sort of our white blood cells. So leukopenia. So that's a low white blood cell count. So that's a decrease in the disease-fighting cells. So if you think of the red blood cells making us juicy and rich with oxygen and stuff, our white blood cells are our fighters, right? They are fighting diseases. So if it's low, now we have a decrease in our ability to fight infection. So sometimes certain disease processes, things like tuberculosis, HIV infection, can cause you to have a lower number. It suppresses your immune system, lower numbers of white blood cell. If our bone marrow has a disease, if our bone marrow has had a toxicity, a radiation exposure, right, you can have a low number of white blood cells. So now you have decreased your resistance to infection, and this actually increases the probability that you'll have some oral ulcerations. So I don't know if you've had anyone in your life that has had like a bone marrow type of cancer and they've had to undergo a stem cell or a bone marrow transplant. They go through a lot of radiation and processes which reduce their immune system, reduce their white blood cells. And a lot of the side effects of that that's not well understood is that the person will develop something called mucositis. And that is a very, very painful oral cavity. Their mouth is so sore and they have like a lot of, sometimes it's not even, you don't see an ulceration. It's just their mouth and tongue is so sore because of their diminished white blood cells and having their bone marrow be affected in that way. Agranulocytosis. So this is serious. This is a serious situation in which you have an extremely low number of granulocytes. And granulocytes is just a specific type of white blood cell. We got a whole bunch of them. We got neutrophils, granulocytes. So that's just one of them. And they are a very important part of our immune system and help the body to fight infection. So it has to do with the bone marrow being destroyed. And signs and symptoms, you could have a severe infection with agranulocytosis, oral ulcerations, or that mucositis. I'm going to actually type that right in here while I'm saying it because I'm thinking about it. Mucositis. Gingival bleeding, bad breath. Sometimes, usually everything causes xerostomia, but for reasons not well understood, persons have it's called copious, meaning a lot, or an increased salivation. Leukocytosis. That's an increase in the number of circulating white blood cells. This means you have more white blood cells than normal. And you're like, oh no, it's a big problem. However, most of the time you will have a transitory leukocytosis when you're sick, right? We need those white blood cells fighting that disease, strep throat. What's another disease? The scarlet fever. You fell down and cut your hand and a dog bit you or something, right? So our white blood cells attack, right? They want to make sure that you don't die, so they're fighting that infection. So having a transitory leukocytosis is normal when you're inflamed, when you've had infection, when you've had trauma, when you're having an allergic reaction. However, you will also have a leukocytosis, an increase in the number of white blood cells when you have cancer known as leukemia, which is a cancer of your white blood cells. So let's look at that one a little more closely. So leukemia is a malignancy or a cancer of your white blood cells. It can be classified as acute, and when it is acute, it means it's very fast growing. It comes on fast, it progresses fast. Fast, fast, fast. Treatment has to be administered as soon as possible for the best possible outcome. So you can have acute lymphocytic leukemia, ALL. You can have acute myeloid leukemia, AML. You can also have a chronic type of leukemia, which means it's slow growing. Let's see. So unlike acute leukemia, so when you have acute leukemia, it comes on fast, needs to be treated fast, you get sick fast. Chronic can go on for years, and it may take years for you to develop any kind of health problem associated with it. So you can also have chronic lymphocytic leukemia or chronic myeloid leukemia. So in ALL, acute lymphocytic leukemia, the bone marrow makes too many lymphocytes. If you have acute myeloid leukemia, the bone marrow makes too many myeloblasts. They also make too many red blood cells and platelets, but the myeloblast is the white blood cell. Treatment for leukemia is highly variable. So for slow-growing leukemias, sometimes the treatment is only monitoring. But for aggressive or acute leukemias, could be chemotherapy, could be radiation, could be a stem cell bone marrow transplant. So sometimes it's even hard to diagnose. Is it ALL, AML? Is it mixed? So leukemia has a lot of different forms, and so there are a lot of different treatments. So some of the signs or symptoms with leukemia may have fever, bleeding, paleness, weakness, recurrent infections, enlargement of your lymph tissues. So if you're feeling someone's lymph nodes, you may feel some hardness to them, weight loss without trying, night sweats. When I'm reading this, I want to add one more for us as hygienists: spontaneous gingival, I spelled that wrong, gingival bleeding. That is a very ominous sign. If someone comes to you and says that their tissues are oozing blood, and without brushing, without flossing, they're just speaking and their tissues start oozing blood. That's ominous, means not dangerous, but like a scary sign, because that is not normal. Look at spontaneous hemorrhages here. Okay, so here are oral manifestations. Bleeding, 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 spontaneous hemorrhage, sometimes oral ulcerations. The gingival tissue can look very overgrown. They have an increased susceptibility to infection. So even though we're seeing more white blood cells, so you're thinking, oh, they can fight disease, they're not formed the right way. They're not able to fight infection. So now you have an increased susceptibility to infection. So what do we need to know, right? First, we're not treating someone that is undergoing treatment. We're not giving elective treatment until someone is in remission. They are very susceptible to infections. You need to consult with physicians about their blood count. Are they safe to be treated? Do they need an antibiotic pre-medication? Because occasionally someone needs to have a tooth extracted in the middle of this process. You need to have strict asepsis, right? We know how to do that. Manage bleeding, because they could bleed much longer than you think. And also to manage any post-treatment concerns for the person. Someone is being treated for leukemia. They need to have a tooth extracted. You don't just dismiss them on a Friday night and say, good luck, call me on Monday if you have a problem, right? They might be calling you at midnight saying they're still bleeding. They might be calling you 2 days later that it is painful still. There could be an infection spreading. So they have to be followed very carefully. Now we're going to be looking at hemorrhagic disorders. So first, let's look at the clotting cascade. Do you remember this from A&P 1 or 2? So there's a lot of things that go on with this. So I'm going to be reading something, and my little notes are below, and they're on the PowerPoint if you want to follow along by looking at my notes. So the process by which blood clots are formed, it's very complex, and they call it the clotting or coagulation cascade. And it's stimulated by clotting factors, and they're all numbered. You don't have to know all of them, just a few, that are released from the damaged cells, known as the extrinsic pathway, and also our platelets, which is the intrinsic pathway. So something happens, right? I don't want to, let's see, what did I do? I am cutting up my delicious food for my dinner, and I cut myself with a knife. Ugh, terrible. On my non-dominant hand. So, within my body, right, I don't have anything wrong with me, my clotting cascade begins. So what happens is clotting factors, and those are all numbered by Roman numerals, 10, 3, cause my platelets to become sticky and adhere to the damaged part where I cut my hand. Sorry about that. My telephone's ringing. I'm going to turn that off. All right. So the platelets are sticky. They go to where I've cut my hand. Also, what's happening at the same time, my body's like, hey, let me help out. It will actually cause the vessel that's cut to spontaneously constrict to try to limit the amount of blood that's gushing out. So the clotting factors themselves will trigger prothrombin, where are we? Here, into the activated enzyme thrombin. Thrombin then converts fibrinogen in our blood to fibrin. And fibrin, I kind of think of fibers, and it actually looks like fibers. All fibers, like, you know, if you have like the jeans at the bottom and you've cut them and you get all like those little, that ragged edge, it's like fibers like that. That's what fibrin is. And all that like ragged edge or those fibers attach to the platelets, and they create this, it's called a platelet plug, by getting your platelets, and they rope them all in and form a clot. Now, when the body senses that everything is repaired, it's all, my cut is completely healed, it will actually release an enzyme called plasmin, and the plasmin will dissolve the clot. So there we go. We got the factors, we got the platelets, we have the blood clotting factors, we have the platelets, and we have the fibrin. All necessary components to form a clot. So some type of hemorrhagic or bleeding disorders, one of them is known as thrombocytopenia. Now you have a problem with your number of circulating platelets. And it could be because the platelets themselves are defective, or you have reduced numbers. And that can be caused from substance use disorder with alcohol, bone marrow cancer, certain drugs, chemotherapeutic drugs, some infections, or nutritional deficiencies. Also, you can have something called idiopathic, meaning they don't understand why, thrombocytopenic purpura. Oh, those are purpurs in between petechiae and ecosmosis. So it's kind of like a middle-size bruise. And this is an autoimmune disorder. We know what that means. The body's fighting itself. So the body is creating autoantibodies and destroying platelets. So that is not good either. So, let me go back. the nutritional deficiency associated with a vitamin that you need to create clots is something called vitamin K. So if you have low numbers of vitamin K, you also are not clotting as well. So when people have bleeding disorders, they tend to have similar common tendencies. So they tend to spontaneously bleed. And I'm not talking about their gingiva. I'm talking about something called epistaxis. And epistaxis is a fancy name for a nosebleed. They tend to get a lot of nosebleeds or moderate to excessive bleeding after a trauma or surgery. So this also, the spontaneous bleeding can sometimes occur into the skin or mucous membrane. So intraorally, you can see this on the buccal mucosa. If they bit their side of their cheek, they make it like a huge bruise instead of like that teeny tiny petechiae. So we just looked at sort of platelet problems, platelets being an important part of clotting. Now we're going to look at a disease process called hemophilia. Hemophilia is a process with the clotting factors. And so there were 3 blood clotting, congenital disorders of blood clotting that we're going to look at. Hemophilia A, Hemophilia B, and then von Willebrand's disease. And it depends on how many factors or clotting factors that you're missing, depends on how severe the disease is. So normal levels of clotting proteins are generally in the range of 55 to 150%. But that is different or much lower when the person is suffering from a congenital bleeding disease. I just put in the clotting cascade made easy again, just to show you here where the clotting factors are. We have clotting factor 3, 7, 9, 11, 12. Look at clotting factors 5, 7, 8, 11, 13. So all of these clotting factors, usually in this image, they have the Arabic numeral, but they're usually referred to by their Roman numerals. So hemophilia, they have severe, they have fewer than 1% of the clotting proteins present. They can have spontaneous bleeding episodes and severe prolonged bleeding after minor trauma. Moderate hemophilia, their clotting factors are in the 2 to 5% range. Less frequent spontaneous bleeding and prolonged and heavy bleeding after a minor trauma. So they hardly have. So if you have severe or moderate hemophilia, you have very few clotting factors present. So sometimes persons with hemophilia are treated with blood transfusions to try to give them some of the clotting factors through transfusion. And you can see here, so when that platelet plug is formed in the normal clotting process, it stays plugged. But someone with hemophilia, the clot or the platelet plug is not made very well. So it starts to leak again. And that's where you can see here, it gets destroyed and the blood just breaks through it. So some common symptoms of hemophilia are prolonged bleeding, bleeding into joints, which can be very painful, epistaxis, which is a nosebleed, and then also bruising. So let's look at the few different kinds. We have hemophilia A, and that is a deficiency of the blood clotting factor number 8, known by the Roman numeral VIII. It's an X-linked recessive trait. An X-linked recessive trait refers to genetic conditions associated with mutations in genes on the X chromosome. So a male carrying such a mutation will be affected because he carries only one X chromosome. A female carrying a mutation in one gene with a normal gene on the other X chromosome is generally unaffected. Hemophilia A is also generally known as classic hemophilia. And we can see here, so the father does not have hemophilia, but the mother is carrying the trait. It's hidden. She doesn't have hemophilia because it's only on one X chromosome. So they have children together. They have a son that's not affected. They have a daughter that's a carrier. They have a son. The son is affected. He received the X chromosome with the mutant or the message of hemophilia on it, and then a daughter with XX. Now you have a father with hemophilia and a mother without hemophilia. Their children, their sons, will not have hemophilia because it must be carried by the mother. And then their daughters will each become carriers because they get the X each time. This X will go with that X, this X will go with this X. So each time the daughter will end up being a carrier because there's only one X here for the father. So hemophilia B is a deficiency in the blood clotting factor 9, known by the Roman numeral IX. Again, another X-linked recessive trait inherited by males from the female carrier, also known as Christmas disease. I'll have to research that a little further because I'm not sure why they're calling it a Christmas disease. And then we have von Willebrand's disease. So this is actually the most common bleeding disorder, usually seen more in women because they tend to have more symptoms due to their menstrual cycle. It's an inherited autosomal dominant trait. So what that means, autosomal dominance is a pattern of inheritance characteristic of some genetic diseases. Autosomal means that the gene in question is located on one of the numbered or non-sex chromosomes. So it's not on the X, it's not on the Y, it's on a non-sex chromosome. Dominant means that only a single copy of the disease-associated mutation is enough to cause the disease. So this is in contrast to like a recessive disorder, where 2 copies of the mutation are needed to cause the disease. One of a common, or Huntington's disease, which you will learn more about in semester 4 when you go to your externship at Tewksbury Hospital, is a common example of an autosomal dominant genetic disorder, as is von Willebrand's disease. So, dental therapy considerations. We need to consult with their physician. Factor replacement or drugs given prior to treatment. Have they had a blood transfusion recently? Have they, what is their list of medications that they're taking? Pre-medication with antibiotics is often necessary. Meticulous home care, right? These persons with bleeding disorders are going to be more likely to respond to local factors, biofilm, calculus, overhanging margins. They need to break up that biofilm to reduce the gingivitis that can occur, the bleeding that can occur. We want to avoid trauma at all costs, scaling in small segments, and then never recommend aspirin or NSAIDs because these drugs can cause someone to bleed more, and you don't want to get that started with someone with a bleeding disorder. Let me just swing back. Factor replacement is talking about the blood clotting factors. So that would be, how do we replace them? Sometimes with drugs, sometimes with blood transfusions, okay? So I'm going to make that clear here. Blood factor. And then last, so you're like, we already talked about anemia in red blood cell diseases. I put this one at the end because essentially you don't have red blood cells, you don't have white blood cells, and you don't have platelets. The bone marrow fails to produce any of the formed elements of the blood. It's not creating any of these things. Some of the causes can be caused from cancer. You have a neoplastic disease of your bone marrow. But also it can be acquired. You could be exposed to some sort of toxin, radiation exposure, maybe certain drugs or a virus, treatment, blood transfusion, bone marrow transplants, followed up with some steroids. You're doing the bone marrow transplants, especially with a donor that might not be a perfect match. You don't want the person to fight the bone marrow. You don't want them to have that autoimmune response to the bone marrow. So the steroids will help to depress that response.